Good morning, everyone. I'm Dr. Tara Kieran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions every 2 weeks together with the Ontario College of Family Physicians. And I'm going to turn it over to the OCFP President, Liz Magad, to introduce the session. Liz?
Thanks so much, Tara, and good morning. And we have a terrific session for you today. I feel we say that every time, but it is true. So looking forward to sharing all the latest updates with you. This session is MainPro accredited, and you'll get that information via email. And then our panelists will introduce themselves in just a minute. Back to you, Tara.
Olivia, can you go to the next slide? So we want to
first I will do this. I'll just do the land acknowledgement. Thanks, Tara, for the prompt. So we acknowledge the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes, and invite all of us to reflect on the territories that we're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I am calling in from unceded Algonquin and Anishinaabe territory.
Next slide. So we're going to be talking about fourth doses today. And, part of the new eligibility criteria in Ontario, it does differ based on whether you are Indigenous or not. And it's important to recognize that people who are Indigenous, they don't have a biologic predisposition to COVID-19, but really it's the structures of systemic racism and discrimination that have resulted in them being more vulnerable to the effects of COVID-19, to them being more vulnerable to getting COVID-19 and being more vulnerable to hospitalization. And so just another reminder of the systemic racism they face, and good that we're able to acknowledge it and prioritize them for things like vaccination and treatments. Next slide. So just a reminder that we're building on past sessions. So we've had lots of past sessions that have talked about IPAC, that have talked about therapeutics. And if you want to access these, please do go to our website. As well, our session today, all of the recording, the slides, as well as the Q&A will be available on the website. The recording and slides are available the same day. And usually the Q&A takes us a few days to compile. Next slide. So I'm delighted to welcome our terrific panel today. I'm very excited about it. I think it's going to be a really useful session for all of you. Next slide. And of course, happy to have my co-host, Liz Magad, join us as well. Next slide. So Francis, I'm going to turn it over to you to just introduce yourself and speak to your disclosures.
Good morning. My name is Francis Garwe. I'm the CEO for Carea Community Health Center, and we operate in Durham region, covering all the 4 municipalities of Ajax, Whitby, Pickering, and Oshawa. And I am associated with Carea Community Health Center, as well as, some of my speaking as a member in the advisory of the Health Commons Lab Solutions. And thank you. Looking forward to the chat this morning.
Thanks, Francis. Isaac?
Hey everyone, I'm Isaac Bogoch. I'm an infectious diseases specialist based out of the Toronto General Hospital and based out of the University of Toronto. Care for lots of patients on the COVID ward and also in an outpatient setting as well. I'm currently working on the COVID wards right now at Toronto General, hence my outfit. I have I consult to a company called Blue Dot, which tracks emerging and re-emerging infectious diseases. And I help the NHL Players Association with COVID protocols.
Thanks, Isaac. Chris?
Chris Simpson from Kingston. I'm a cardiac electrophysiologist here clinically, but I'm here in my capacity as Chief Medical Officer at Ontario Health, which is the health agency overseeing large chunks of the healthcare system in Ontario. And I don't have any disclosures to report today.
And David, next slide.
Hi, I'm David Kaplan. I'm a family doctor here Toronto. I'm also with Ontario Health, the Vice President of Quality, and I receive a speaking honorarium from the Ontario College of Family Physicians and employment income from Ontario Health. Glad to be here.
Liz?
Hi, Liz Mugga. I'm a family doc in Ottawa and also the president of the college. And I receive a stipend for that role.
And I'm Tara Kieran, and I've just listed places where I get grant or salary support, as well as where I've gotten some honoraria. I don't think any of these pose conflicts for today's talk. Next slide. So Olivia, are you able to go to the next slide? We do have an exciting session planned for you today, and I'll just give you the outline for it. We're going to start with Mr. Francis Garwe, who's going to be talking about an equitable recovery and really some strategies that he's been leading at the Carea CHC that I think will help to inspire all of us. Next, we'll be moving to Isaac Bogoch, who'll be giving us an overview about where we are with COVID and also talking about fourth doses and the state of immunity in Ontario. And then after that, we'll be going to, we'll do lots of Q&A, of course, but then also going to David and Chris. David and Chris will be talking to us about therapeutics and how we can access them and some new pathways that are going to be coming up that'll be really relevant to us. We might talk a little bit more about Paxlovid, and of course, we'll have lots of time to share Q&A. So I know we've been having a bit of trouble with the slides, so hopefully that's worked out now. We're going to go to the next one. And the next slide is just a reminder that, of course, the Q&A is a huge part of what makes this community practice special. So if you have questions, please put them in the Q&A box. Please, use the chat to share your comments, to share resources, but really put your questions in the Q&A box. And if you like a question that someone else has asked, please use the thumbs up to upvote it instead of asking your own question that is slightly differently worded. I'll be prioritizing the questions that have gotten the most thumbs up. Great, so next slide. So I'm delighted to introduce Francis Garwe, for him to introduce our session around and speak about an equitable COVID recovery. Francis, to you.
So good morning, everybody. My name is Francis Garwe, coming from Carea Community Health Center, and we are operating in Durham region under all the four main 401 municipalities of Ajax, Pickering, Oshawa, and Whitby. So this morning, I'm going to give you the Durham context in terms of what have we learned from what we have seen during COVID. So what you are seeing here, the concept is coming actually from speaking about the high priority communities that we identified during the time of the peak of COVID. And the timelines, starts from January as of 2021 to the current situations. What I'll walk you through, hopefully if there's something that you can take away today, is the understanding of the social determinants of health, and a little bit of why is that concept important in terms of supporting your patients, your clients, as you continue to give care across the regions that you serve. But also as a point of maybe clarity, is this situational opportunity may not reside in the area or maybe not be available in the area that you are in. So I just want to make sure that I'm mindful as I share that. So if you have questions, context at the end of the presentation, you will notice that you have an opportunity to have some contact information on who within your area will be able to give you some additional information that you require. So if you look at the diagrams that I have here, so one thing that I want to share, when the high priority community strategy started way back in January, there were lots of opportunities that were identified there in terms of the prevalence in the community, identifying these FSAs by those area code in terms of where exactly were the issues and what exactly was happening within those contexts. So two things to take away, hopefully at the end of this chat. when you understand what exactly are some of the social impacts which touches some of your patients, your clients in your area, what are some of the cultural nuances that actually impact them as they access care from your practice, from your teams. But the diagram that I'm sharing here, as you see it, it's actually, I'll give that compliments to my colleague, Dr. Kwame Mackenzie from the Wesley Institute, in which they actually flagged some of the populations that you probably are interacting with within your communities. This was shared based out of the information gathered from Toronto, what was seen within the Black community, Latin America, South Asian, and Southeast Asian communities in terms of the prevalence of them, versus the majority of the white population in terms of catching COVID. So next slide, please. And what we have learned from the previous situations has actually helped us think about what does the future of recovery look like as we continue to interact with the communities at multiple levels. And thinking about the lessons that we have taken based on the impacts that we have seen, where we were delivering healthcare and supports with the interprofessional teams using the ambassadors across the communities. We have learned a couple of things that, if anything at all, would be useful for your teams to think about. And as I go back onto the slide as we go towards the end, I'll give you a little bit of tips on what to look for and what are some of the supports that you can get. So in looking forward in terms of the transition for the wellness hubs that we have created now as a way as we move towards these phases of the pandemic, we've created what are called mobile health hubs. These mobile health hubs are specifically geared to do two things: provide the just-in-time supports for the communities in which the prevalence of COVID is in the communities. You will hear probably from other speakers as we go on. They will talk about the water waste management and the results that will come from there. Our information is informed also by that kind of data. So for the mobile units, the way how they work in this space is they identify these high priority communities. And when these hubs are actually operating on any given day of the week, the idea is to make sure that we focus that information on health teaching that's happening from members of the communities that are hired as ambassadors who speak the language of those communities, who understand the cultural nuances, who also understand the social and economic factors that impact those folks. The idea being that the more you give that education right in front, it allows the folks and the community members, and including the providers, to understand what else besides the sustainability do these patients have, besides the fact that every one of us probably by now, we are ready to say, we're gonna catch COVID one way or the other. But what is it that I need to do or to learn so that I can prevent some of this? And even if I was going to catch it, who is within my network that can help me? But also as a solo physician, or even if you are in an organized primary care space, who do I need to make sure that I'm connected with? And how can they support those patients that are within my practice, especially those that are chronic or who are facing chronic conditions, diabetes, COPD, CHF, and probably some people that are under-sheltered who could be also users of illicit drugs within the community. Next slide, please. So some of the small activities that I can report here, and when you look at this data, it may look like, wow, maybe it's a little bit smaller, it's insignificant. But here are the couple of pieces that I just want to highlight. This data was gathered between April 1st of 2021 up to March 31st of 2022. Look at the number of CPRs that we have done in terms of the pop-up clinics that we have done, across these communities. So the crucial aspect here that you will need to take away is notice that these are normally patients and community members that are hard to reach. And again, think about the concept that probably their circumstances, based on their income, based on where they live, based on their health condition, they would not be folks that you would otherwise see right at the forefront. The system interacts with them at the last moment of normally their situation, whether they're in a hospital or they could be by that time maybe way down the line in which the situation is no longer reversible. So our opportunity, as we learn from that data, was specifically go right in front of the situation, right at the top of the hour, to make sure that we understand what's there. And the information that we have gathered here as we're going through even these swabbings, we were able to learn the way how they would actually prefer to interact with the system, and how does the system help them be able to take care of most of their health. We know right at the beginning of COVID, two things we have taken away is COVID is a community really disease. It actually impacts us more as we do our day-to-day activities. But for us, what we have learned from there is further to say, where do we need to make sure that we get ahead of the game before things get worse? And the last piece of the slide here, what I'm just showing, is what has happened now within these mobile units, in which now we decided to say, maybe the most impactful thing is to give control within the community, within the families, by distributing some of these RATs, these rapid antigen test kits, so that the community can do this within their home. But when they have control in terms of testing themselves within their household, they're able to even alert you as their provider right ahead of time of some of the challenges that they are facing, but also prep you in your next visit as a provider in terms of, so what other things should I watch for? What questions should I ask to make sure that these folks continue to take care of themselves and prevent themselves from getting sick, if not worse, dying. Next slide, please. So what you are seeing here is just a true picture of what happens in the mobile hub. Right at the top left on that picture in blue, you'll probably see the nests in these activities and interactions are happening right inside the van. Notice when you come into these mobile units, two things are very crucial in there. They do all the wellness checkups that you can see. They check your blood pressure. They also do wound dressing. But they also gather a lot of information about your history, other things that are happening within your home. And from this interaction, sometimes there are activities that are not being able to be performed within the vehicle, the mobile units that you are seeing. So now we pull an opportunity to bring you into a clinic to be able to support you. Notice that you do not have to be rostered to a high priority community initiative team. This team is open to any community provider, whether you're an NP, a physician in the community. Your patients who are actually facing some of these barriers of accessing care have abilities to access this team, where they get the health teaching, some tools that they can keep, including other resources such as case management supports that would include rental support, food and nutrition guidelines from dietitians, health promoters, as well as some specialists that focus on, hepatitis C and diabetes. All the tests that we are talking about, the blood dry testing, happens in these vehicles. So within 20 minutes, you walk away knowing as that, community member or the person who is looking for care, knowing whether the supports that you are getting can be, resolved within this space, or when your next appointment will be to be supported further. Next slide, please. So as I speak about this, what are some of the key ingredients of making this work successful? As you notice, partnerships are crucial in this work. Whether you're a solo physician or working within a network, these are some of the networks that we've utilized in Durham. In Durham specifically, there's Durham OHT, which constitutes all primary care providers that are within the region, and also community health centers that are also supporting the community, plus grassroots organizations that are in there. Why is this important in your context, wherever you are, to understand what resides or what services are in your space? This allows your patients or your clients to be able to get the just-in-time supports. But also for most of you as providers, you do not have to do it all by yourself. These opportunities with these partners will be able to resolve some of the early indications or challenges that your patients would be facing. And these organizations will be ready to support. So as we go further to the next slide, please, I'll show you some of the partners that you'll probably be identifying with quite well within the regions that you are serving. These are a list of 16 lead agencies that were appointed by the ministry right at the beginning of the COVID. 16 of them are spread right across areas where we have FSAs that had high prevalence of COVID. Whether you are in Durham or you are in Mississauga, you are in Brampton, you are in Ottawa, if you take note of all these agencies that are listed in here, these are the folks that you can give a quick call, depending on where you are, to say, hey, I have these patients that could really utilize some of these supports. And why is that important for these kind of organizations to be connected with you? They'll provide this true integrated wraparound support for the most hard to reach patients that will be crucial for the kind of service that would not be offered just within your primary care environment as a solo practitioner, or in an environment where you have limited resources to support them. So what I would do is I will pause right here to make sure that for those of you with questions, you can send them in the chat. We can help to guide you and support you with who you need to talk to next. Thank you very much. I'll pass it on to the next presenter.
Thank you, Francis. I'm just going to read this comment from the chat from Rebecca Ray, who says, a huge thank you to Francis and the Carea team. They've been an integral part of our COVID response team in Durham region. Their approach to swabbing and vaccination, as well as innovative patient care, is commendable. So glad you can share your success here today. So, I really thank you for highlighting and reminding us again of the inequities that became, so obvious and front and center during COVID, but also that there are things as healthcare providers and organizations that we can do to address them and that we need to do moving forward. Not all of us have the privilege of working in a team-based model. And so it's terrific to hear, that family doctors can work together with these lead agencies and high priority communities to help patients get the care that they need. I know many of us have been inspired by your talk, so thank you. I'm going to shift gears now, because I know at the same time as we've been thinking about recovery, and actually even, we planned this talk on recovery some time ago, we're back now in the thick of it, thick of COVID. And I'm going to turn it over now to Isaac. Next slide. And Isaac, I'm going to ask you to tell us a little bit more about where we are in Ontario when it comes to COVID. Are we in a sixth wave? What does that mean? I noticed that some of my colleagues have also asked about, our role in advocacy around that. And then the other big thing that's happened, of course, is that there have been announcements around fourth doses, and I hope that you can bring us up to speed. And there's lots of questions about that, so I'll ask you those questions after you give us a little bit of a talk.
Wonderful. Thank you, Dr. Kieran, and thank you for the opportunity to chat with everybody today. Obviously, it'd be much nicer to do this in person, but these are the circumstances, and I look forward to the times where we can all get together in those massive conference rooms, have a chat, and we'll get there. Also, a big thank you to Francis. That's a very inspiring talk, and wonderful to hear the work that's being done in Durham. And hopefully we can see that copied and pasted in all the other regions. That's just a wonderful model for care, and some incredible appreciation of the social determinants of health and how important that is to acknowledging that in the provision of care. Okay, let's jump into Ontario and the sixth wave that we're in. If you look at the screen, you can see the combined wastewater signal for the province. Not hard to interpret this graph. It's headed this way. Translation, there's a lot of COVID in the community. This is an aggregate of multiple jurisdictions, wastewater surveillance. So if you break it up and you look at Eastern, Northern, Southern, GTA, all these areas, they're all headed in the wrong direction. And when I look at the wastewater signals, it only tells me two things. Number one, it tells me the direction of the pandemic, this way. And the other thing it tells me is the regions that are impacted, all of them. That's it. I think it's very hard to look at that graph and quantify the true burden. It just tells us trajectory and location. And, it's still ugly, right? We still have a lot of COVID. in the community. There's probably growing numbers of COVID, a growing burden of COVID in the community. And now we're starting to see the predictable uptick in hospitalizations. I think there's still uncertainty as to how big this wave will get. Most of the modeling, first of all, the initial science table modeling undercalled the size of this wave, and this wave will be larger than what the science table projections initially came out with in terms of hospitalizations and ICU capacity. I've seen some updated modeling, and it looks like hospitalizations, at least at this point, it's predicted that they'll be about half to maybe 2/3 of what the last wave demonstrated. That's still a lot of people in hospital. Even if it's smaller, it doesn't make those hospitalizations and of course those deaths and those infections any less important. They're still important, and you know, obviously there's steps that we can take to at least mitigate some of this wave. The obvious solution is masking. I think we should all be advocating for masking in community settings, especially indoor community settings. It just makes sense. I mean, I appreciate how masking can sometimes be, for whatever reason, it can sometimes be a contentious issue, and some people have very strong opinions one way or another. I'm under no illusion that masking is going to stop a wave or be 100% perfect in preventing infection. Of course it isn't, but it does reduce the risk of infection. And if everybody masks, it does reduce the impact of a wave. And there's just an enormous body of evidence suggesting that. But no, they're not perfect. But of course, you know, I think it's very reasonable to be wearing masks, and actually should be strongly encouraged. People should be strongly encouraged to be wearing masks at this point in time. So we'll probably peak in the next week to 2 weeks-ish, maybe closer to 2 weeks, and then this wave will recede. I find it very challenging to look at other jurisdictions and make direct country-to-country comparisons. Having said that, if you look at other jurisdictions and make direct country-to-country comparisons, you can see that Europe, which is usually a few weeks ahead of us, most European countries have had a wave. The wave wasn't as big as the most recent wave, and most, for example, Western European countries, countries that we like to compare ourselves to, are actually now receding. And these are countries that have comparable rates of prior infection, comparable rates of vaccination, including third doses. So, you know, all arrows are pointing in the direction of a real wave, which we're in the midst of. And then, of course, this wave not being as big as the last one, and this wave receding or starting to recede probably in the mid to latter, mostly latter part of this month. But of course, there's things that we can do to protect ourselves, mask. And I think there's still some under-vaccinated individuals and under-vaccinated communities, and significant outreach to those communities would be extremely helpful. Speaking of vaccines, next slide, please. Let's chat about fourth doses. So NACI has opined on fourth doses. Ontario has opined on fourth doses. The Venn diagram mostly overlaps, but doesn't entirely overlap. As we know, there's science, there's policy, and somewhere in between. So if we look at the science of fourth doses, who would really benefit from a fourth dose? Please, let's timestamp all of our conversations, because as we have more data, that will translate into changing policy, as we've seen time and time again. But if we're timestamping this conversation and discussing what is a reasonable approach right now, the following things I think are reasonable. Number one, the people who would most benefit from a fourth dose are very frail, elderly, or immunocompromised individuals. That's that. Now, it's hard to draw a line in the sand and say, okay, everybody over X age is eligible for a fourth dose, and have people stampeding to say, I'm going to get a fourth dose. However, if you look at the available data, it really most benefits frail, elderly individuals, individuals with underlying medical conditions that would put them at greater risk for severe outcomes from COVID-19. And when we look at who's in hospital right now, it's really people over the age of 80. It's also really people over the age of 75. It's people with underlying medical conditions. It's immunocompromised individuals. And again, just to take a step back, that's not taking anything away from those poor individuals that are sick and in hospital. And we have tools to protect populations, masking. We should be using those tools to protect the most vulnerable individuals and vulnerable communities. But the vast majority of people who get COVID, especially Omicron, are not going to end up too sick and in hospital. They still feel crummy, but really we should be taking steps to protect the most vulnerable. So yes, I appreciate that NACI has said 80-year-olds should really think about getting this, and you can consider giving it to 70-year-olds. I appreciate that Ontario has said 60 and up are eligible. If the question is who would benefit from it, it is frail, elderly individuals. Now, does that mean you have a battle royale with your 61-year-old patient who's still running half marathons who wants to get this vaccine? Of course not. I mean, it just comes down to a conversation of what benefit are you going to get from this vaccine? And a healthy, fit, otherwise well, person who's still eligible probably isn't going to have the same degree of benefit from this vaccine as someone who is significantly more frail or elderly or vulnerable. That's just what the data shows now. Couple of caveats and a couple of things that we always have to acknowledge when we're having this conversation. Number one, the data isn't ideal. The data will change with time and the policy will adapt with the emerging data. Number two, there most certainly will be a time to roll out additional boosters and fourth doses to the general community. That time might not be now. We're seeing a gradual expansion of this, but I think we have to look forward to late summer, early fall 2022. It's expected that we are going to have a predictable rise in cases in the fall, and we should already be planning for how to potentially roll out vaccines at that time proactively so that we're not caught flat-footed. I don't know if we'll need them then. I don't know if it'll be widely, if there'll be data to support that, but we should at least be prepared to do that and be prepared that this might overlap with influenza vaccination as well. So something to think about. Point number three, you can't have a conversation about fourth doses of vaccines without acknowledging that there's over 1 billion people on the planet that haven't had a first dose of a vaccine. This is especially relevant given the first 5 minutes of the conversation talking about equity and social determinants of health. There are under-vaccinated communities and populations, not just in Canada, but of course, globally. And the last point to consider with fourth doses is in the next 2-3 months, we'll probably hear more data on an Omicron-specific vaccination and the utility of that. That, again, this is pure speculation. If it's around, if it actually works, we might hear about that in Canadian settings later on in the year if we do need that before a predictable rise in the fall and winter. So those are the standard caveats to the fourth dose. I'm going to look at Dr. Curran and ask, am I missing anything at this point in time, or should we move on to the next speaker?
Well, there's lots of questions actually around the fourth dose. So this is a great opportunity for a segue, but I'm going to go to the next slide. And I just wanted to flag for folks, this is the actual eligibility here in Ontario. As of Thursday, and I don't know, Isaac, if you want to speak to that, but there is also like a recommended interval of 5 months, but I think the actual eligibility is 3 months. So it's a bit confusing that way. And it's for Ontarians 60 plus or people who are Indigenous and their non-Indigenous household members age 18 or older.
Right. So like, listen, if I think NACI has knocked it out of the park for the most part, some of their comms earlier on, but for the most part, I think from a policy standpoint, they've been really, really data driven. And again, I appreciate there's sitting in an office and sitting in a clinic, chatting with a patient face to face who is, asking about this vaccine and of course, translating good, sound scientific evidence into policy and then moving that into the clinic space and at the bedside. But NACI said it's appropriate to wait 6 months for that fourth dose after the third dose. But there's a lot of wiggle room in that wording. And they said, given different circumstances, that can be shortened. Well, how about the circumstances of a pretty impressive sixth wave where you've got vulnerable people who are certainly at risk of getting this infection? So I would not be married to that 6 month. And I think, within that 5 to 6 month interval, that's fine. And people sort of want to say, well, what about 3 months? What about 4 months? Yeah, sure, of course you can do it. There's always wiggle room. But I think that I'd try to adhere as much to the NACI guidance as possible. And again, we sort of touched on NACI really thinking this is ideal for the 80+ crowd, with a caveat that, yeah, of course, there might be some people in the 70 to 80 category that might be vulnerable. And of course, you can consider vaccinating them. And Ontario sets that bar at 60. The United States set the bar at 50. I mean, I just don't think that those individuals, again, based on the data that we have to date, would have the same degree of benefit with this. And people say, well, what's the harm? And the answer is, it's a medical intervention. There, of course, are risks to this, not significant ones, but you can't say there's zero risk to this. So you really have to think about the risk benefit, and that risk benefit ratio strongly favors frail, elderly adults based on the data we have to date. Last point, the goal is to prevent severe infections. The goal is to prevent severe infections. Immunity to protecting against symptomatic infections is going to predictably wane and wane quickly. The goal is to keep people out of hospital. I think if people have this mindset that we're trying to prevent infection, unfortunately with Omicron, you're going to be disappointed.
Thanks, Isaac. So I think you've answered a lot of the questions, but I'm just going to summarize some of what I've heard that I think is answering some of my colleagues' questions. So some of them are saying, what's the best interval between the third and fourth dose? You're saying NACI got it right, but of course, you know, if it's 5-6 months, it's the sixth wave right now. Of course, you know, we can use some of our judgment there. And I think there's also a question about, you know, what is the incremental benefit of this fourth dose? And I think you've answered that really it's for those frail, elderly, and others it's not. There are people asking about fourth doses for healthcare workers specifically. And the other thing people are asking about is, does it affect your chances of getting a booster in the fall? Like, let's say you get the booster now, does that mean you're left more vulnerable in the fall? So I don't know if you could answer those two things.
Yeah, so from a healthcare worker standpoint, honestly, I don't think it's going to have any meaningful impact whatsoever unless you're a frail, elderly, immunocompromised healthcare worker. I don't think it's going to provide incremental benefit, right? The whole goal is this prevents you from getting sick enough to land in hospital. And we see that third dose is really, really good. But the incremental benefit of a fourth dose for younger cohorts that are not immunocompromised, I don't see it just yet. But again, hey, give it time. Let's see. What was the second part, Tara?
The second part was, now I'm forgetting what the second part is because I read all these other questions. I'm going to go to a few other questions. So the other questions are related to if you've had an infection. So given recent reports that reinfection can occur within 30 days, what should we be telling our patients regarding how long they should wait for their booster infection? So that was from A Song.
Yeah, so sure, reinfections can occur. That's clear, but based on some of the most recent data, it's not a common phenomenon. Of course, it can happen, but if people have been infected, you've pretty much bought yourself, for the most part, you can't speak in absolutes, at least 3 months. And it might actually be longer than that. And NACI's even come out and said after an infection, if you're eligible, for example, for a third dose, you should wait a minimum of 3 months before getting that third dose. And it's not just because the risk of reinfection is so small in that initial 3 months. It's also because that way you will, based on how your immune system works and presenting antigen to your immune system, that way you'll actually mount the more meaningful immune response to provide you with the greatest degree of protection. So 3 months after infection for vaccination, let me rephrase that, at least 3 months after infection for vaccination is the way to go.
Thanks. So another question about mixing mRNA vaccines for the fourth dose, any evidence around that? And anything to know about side effects of the fourth dose?
Yeah, so mixing vaccines, there are antibody studies that demonstrate that there might be some benefit in mixing mRNA. So if you had Pfizer, go with Moderna. If you had Moderna, go with Pfizer, because you make a more robust, diverse immune response. But Does that actually translate clinically into better protection? I don't know. Is it harmful? No. I think it's pretty reasonable to do. But you know how when we talk about what is the evidence and the quality of the evidence, I think there's theoretical benefit of that. And I've been saying, you know what, if you can do it, go for it. But I wouldn't die on that hill. Like if you show up to the vaccine clinic and they have Pfizer there and you had Pfizer already, okay, get Pfizer. But, there's theoretical benefit of that. And that's actually pretty recent. That data came out about 2-3 weeks ago. But there's no hard clinical evidence. So, it's moderate level evidence for mixing and matching. Like I wouldn't make a policy about that, but I certainly would say, like, if you can do it, it's worthwhile.
And so how about the side effects? Is there anything new or anything notable we need to know that's different about the fourth dose side effects?
Nothing that I've seen. Remember, the evidence for the fourth dose is scant at best, right? We have one peer-reviewed article that's clinical. We've got some preprints and we've got some laboratory-based data. So there's very, very little. Based on everything we have, it seems to be well tolerated with few to any side effects. Also remember too, this isn't a cohort that's older, right? Most of these studies looked at people 60 plus, 70 plus. So those rates of, for example, myocarditis and immunologic phenomenon, just they're rare. They're certainly rare. So I haven't seen anything like that.
So thanks to David Kaplan for putting that article that you mentioned from the New England Journal, the link to that in the chat, so you can check that out. I think there have also been some questions about pregnant women or pregnant people and fourth doses. Are fourth doses recommended for pregnant people?
No, unless they're over the age of 80, which would be highly unlikely.
Okay. And if you do get a fourth dose, the question I'd asked before that we had forgotten what I'd asked was, does it make you less likely to get it to get the booster in the fall? Like, does it impact your ability to get another vaccine maybe that might be more beneficial?
Honestly, I don't know. I truly don't know. But yet again, another reason to really provide scientific, data-driven, patient-centered advice. Some people would really benefit from this. Many people who are eligible will probably not have the same degree of benefit from this, but probably will benefit from a future vaccine, maybe an Omicron-specific vaccine that's available before the next predictable surge. Those are tough conversations to have at the bedside, because I appreciate you might have someone who is 59.9 years old who lands in your clinic demanding a fourth dose of a vaccine because they really don't want to get COVID. And those are challenging conversations because A, that individual might not get the same degree of benefit, if any, from the vaccine. B, we're not stopping infection. That's the key point. And people will still be getting infected with COVID, regardless of how many vaccines they get. You might ever so slightly reduce the risk of infection, but the key here is to prevent severe infection like hospitalization and death. And 60-year-olds who have had 3 doses of a vaccine have very high rates of protection against hospitalization and death, especially after that 3rd dose.
Thanks, Isaac. I mean, I think that
timestamp though. Like, this is an early field. There's emerging data. We will learn more as we go. This is the best you got for April 8th, 2022, 8:39 a.m.
Thanks, Isaac. I think people appreciate that bottom line. The goal is to prevent severe infection. Ravi Murthy was saying that that's really crystallizing. And, Sandra Khan saying there's a difference between eligibility versus recommended, right? So I think that's what we're getting at here. People are saying they've gotten patients that they've had many patients who've been reinfected after 1 or 2 months. So just putting that out there. But I want to take one last question, which is a different topic.
Sorry, I don't deny that it can happen. But if you look at 14.5 million people in Ontario, remember, we have a selection bias. Yeah. And also, if you're using PCR, be very careful to say that that's a reinfection. Be very careful to say that that's a reinfection.
And that, I was going to say the same thing as Isaac. We're seeing a lot of other rhinoviruses right now in the community in addition to COVID, because everybody's mask is off. So I think you have to, if it's PCR,
there's flu.
There's
influenza out there too.
And I think Isaac, I think it would also be helpful to remind people that people who got infected and had a positive test, and even in mid-December, only 50% of them had Omicron. So it's definitely possible for people to have Delta in December and Omicron now. So that's definitely,
that's an absolutely. However, about a third of the province got Omicron and recovered, and the vast majority of people have had 2 doses of a vaccine, which again, like, we can't ignore the incredible protection that 2 doses of a vaccine provides people. 3 doses is better, but 2 is still incredible protection against severe illness. Like, I think sometimes we frame the conversation that, like, we're treating 2-dose people as if they're unvaccinated. What? Have you looked at any of the graphs? Yes, we should be getting 3rd doses in, and we're certainly under vaccinating people, but like 2 doses still protects very significantly against severe infection. It's just 3rd doses are better.
Thanks. So I want to switch gears a little bit to a different question that, so Jennifer Trans asked, what is the estimated rate of false negatives for RATs? And I think this really relates to the larger question of how they should be used and how much we can rely on, I guess, a negative RAT.
Sorry, was that for me?
Yes, that was for you, Isaac.
Can you say that one more time? I was reading the comment section.
That's okay. Jennifer Tran said, what is the estimated rate of false negatives for RATs?
Oh, okay.
And I think that relates to the broader question of RAT use and how we should be using them. So it's a tough one. It's a big question.
So here's where everyone hates me. 798 people on the call. Let's reframe the question. Don't you hate when people say that? Well, I'm going to say it. Remember what an RAT does. Remember what let's ask the question, what does the rapid test answer? The rapid test answers the question, am I contagious to other people right now? Yes or no? That's a different question than, am I infected with COVID-19 right now? Yes or no? You can increase the yield of the RATs by swabbing the cheeks and the back of the throat before the nose, but the question is different. So when you're talking about false negatives, presumably you're comparing that against a PCR test, which will detect the tiniest little shreds of virus genetic material in the back of the nose. Those are 2 different questions. You have a tool that addresses a question. Don't repurpose that tool for something else, okay? Yeah. You can have a lot, and remember, most people are vaccinated. People can be infected, they can feel crummy because of your immune response to the infection, but not have a ton of virus genetic material in their back of their nose or throat such that they'd infect other people. So RATs aren't perfect, I get it, but they answer the question, am I contagious to other people at the point in time that I'm doing the test? Not, do I have shreds of virus genetic material in the back of my throat, and is that the cause of me feeling unwell? Different question. So
Thanks,
when
Isaac.
people here say sensitivity, like, it's kind of not the right question to ask. If you're asking, can the RAT test pick up COVID? The answer is, yeah, of course it can, but it's meant to answer the question on transmissibility.
That's really helpful. And Jennifer Tran says, thank you. Excellent reframing. We'll forgive you. Thanks. So there continue to be lots of questions, but I do want to get to our next speakers. And so there are questions about Novavax. There are questions about teen boosters and other things. If you have time, Isaac, while Chris and David are talking, you can go into the Q&A and answer some of them by typing. But we'll get back to the oral Q&A after Chris and David. So I'm just going to go to the next slide. The next slide, I just wanted to highlight for folks that some of you, I think, are struggling with some patients who have allergies. And this is just a tool that the Ontario Medical Association section of allergy has helped to put together for how to navigate COVID vaccination for people with allergies. So we'll put that link in the chat, and it's in the member page, and hopefully this can help you to navigate it. this situation. Next slide. So I'm going to turn it over to you, Chris and David, to tell us a little bit more about where we're at with therapeutics and where we're going to be going.
Okay, thanks, Tara. I'll kick things off, and then I think David will be the second half of our tag team. So we can go to the next slide. So just a little bit of an overview, and we'll dig into these just a little bit. But first on Paxlovid, the current state is that it is available through clinical assessment centers, and there are nominally around 80 across the province. And these were stood up very quickly from the old assessment centers, i.e. the testing centers, and they had their functionality expanded a little bit in order to be able to provide assessment in addition to the testing, as well as dispensing of Paxlovid. There are also a number of local pathways that have popped up that many of you will know better than I. And I'm also aware that there are areas in the province where these local pathways are not readily apparent. So as with any kind of new thing that's established quickly, there's been a little bit of a patchwork approach, although an attempt to standardize this as much as possible. And it's also worth noting that this happened at a time when there was relatively little Paxlovid supply, and it began at the denouement of wave 5 with diminishing new infections. And so for all those reasons, the uptake of Paxlovid in the early going, after the science table published their recommendations in late February, has been a little bit lower than anticipated, although that language may be a little bit pejorative in that I would argue that perhaps we should have anticipated there wouldn't be quite as much Paxlovid uptake at that time when infections were decreasing. Now, of course, the story today is very different with us well into wave 6. And I'm talking to you from KFLNA, which I think has the highest community transmission in the province right now, and we're sure feeling it. It's important to note as well that we're no longer experiencing any supply constraints. So there really should be no kind of rationing vibe or, sense that there's not enough Paxlovid, and there's lots more coming. So any clinical decision-making that might have taken into consideration a limited supply, I think that largely has been lifted now. And David will talk a bit more about this, but we're taking steps to establish broader community access to Paxlovid. So we want to really remove as many barriers as possible on the accessibility side, which is not to talk specifically about the eligibility side and some of the complexities of prescribing Paxlovid and following patients who are on Paxlovid. But in terms of access, we're anticipating that in the next week or so, there will be much more clarity around where you can get this stuff, should you choose to prescribe it. The second bullet point on this slide is sotrovimab is no longer recommended as a treatment option for outpatients or those who are mildly ill, i.e. not requiring supplemental or additional oxygen or requiring hospitalization. This was provided in 8 sotrovimab centers across the province, which were stood up by the ministry in the early days. And the science table's feeling now is that there's good evidence that it is not effective against BA2. BA2 is now responsible, we think, for over 50% and growing of all infections in Ontario. And because we can't sort out BA2 from other variants at every individual case, the practical consequence of that is that sotrovimab is no longer recommended. And so those centers that are providing this therapy are transitioning to providing IV remdesivir, which is appropriate for both mildly ill outpatients and moderately ill inpatients. And so because it's an intravenous therapy and these structures were already up, the decision was, well, let's just keep them going. And then finally, Evusheld is a new drug that will be for pre-exposure prophylaxis. So this will have a different indication, largely for immunocompromised patients. It won't have that time frame problem that that Paxlovid has, so it doesn't have to be administered after, within 5 days of infection. It's administered to high-risk people before they're infected, and in a much smaller group of people, i.e. the immunocompromised. And we're anticipating at this point Health Canada approval probably imminently, I think, in the next week or two, and we're led to believe that supply will be very close behind. So stay tuned on Evusheld. So I'll just go to the next slide and then the one after that. You'll have seen this table from the science table's recommendations around Paxlovid. And I won't go over this in detail because you all know this better than I, but basically the idea here was to pluck out a population of people who have a probability of hospitalization following infection of 5% or more. And identifying them as particularly high risk. That's not to say that people who fall outside these high risk categories might not benefit from Paxlovid. But if we're really targeting, to some of Isaac's earlier points around vaccination, if we really want to target the high risk people and get the most bang for the buck, these are the kinds of patients that we would want to target. So there's a stratification based on age. We've always known that age is a major risk factor for bad outcomes with COVID. So age is there. The status of vaccination, so less than completely vaccinated. Or completely vaccinated, recognizing that there's some definitional debate around whether that's 2 doses or 3 doses. And then another list of risk factors like obesity, diabetes, hypertension, et cetera, that you can see over in the far column. So combinations of those factors determine whether you're at a higher risk and would benefit. And so, thinking about the number needed to treat, which is of course, the inverse of the absolute risk reduction, the back of the envelope would suggest that you'd need to treat about 25 of these people to prevent 1 hospitalization. And then, by any measure, that's a very reasonable, high impact intervention. But I think we all know that, if a 70-year-old if a 67-year-old with 3 risk factors comes in, how are they any different than somebody who's 70 years old? And so David will talk a little bit later about, how we really want to empower clinical judgment to inform decision-making, again, especially in a setting where Paxlovid availability is not an issue. So there is an opportunity, I think, to color outside the lines a little bit here and think about these not so much as eligibility criteria as a way to identify the highest risk people, but there may well be lots of other, appropriately high risk people, even if they're not as high risk as these folks, who could be eligible, and we certainly don't want to discourage that. The next slide also is around current state, where to get treatment, and you'll be familiar with this. And David is going to talk about later about where we're migrating to, hopefully very quickly. We know that a lot of people who've heard about therapeutics and have symptoms of COVID-19 may be reaching out to the people they trust the most. And in many cases, most cases, that's their primary care provider. But there are many other people, of course, who seek out care based on how bad they're feeling. And we sort of have to decouple the severity of symptoms from the assessment of how high risk you might happen to be for developing serious illness. So there's a little bit of a difference there that might discourage a lot of people from calling you until they're day 3 or 4 into their symptoms, at which point the time window for Paxlovid is closing pretty quickly. So nevertheless, people in all stages of illness are going to be contacting you, and the emphasis has to be on early intervention as soon as possible after symptom onset in order to have the best chance if they are Paxlovid eligible. So that can be done through their primary care provider, who can link them to appropriate testing and to treatment. That may include sending on to a COVID-19 clinical assessment center if one is nearby. The telehealth has scripting, which will direct people to clinical assessment centers. Again, this is current state. Patients can also get assessed through their emergency departments if needed, and there are many places in the province where the emergency department is the place where people go, and that shouldn't be discouraged. And there has been some guidance provided on how to prioritize, how to assess, and direct patients to treatment, including a sample script available to your admin staff in terms of pointing people in the right direction. The next slide, and I won't pause on this for too long, but this basically just summarizes what I just said about the current state, where to get treatment. And then the next slide really is the problem with everything I just said. And so we know that the eligibility criteria have been complex. Certainly the public health messaging, for the last little while has been, if you're mildly ill, stay home, you don't need a test. And now we're saying, well, unless you're over 70, unless you have these high risk conditions, it's a very, very difficult kind of public message to communicate, and apparently conflicts with the predominant messaging that's out there. So very complex for the public to understand. There has been a lack of public awareness about antivirals and who would be eligible. CACs are a new window to the healthcare system. It was originally intended for a fairly narrow group, and it was in a limited number of locations. We've tried to really expand that, but it's not going to be and shouldn't be the only channel at all to get Paxlovid, or if we're thinking of the future, the huge number of therapeutics that are liable to become available. We know that the CAC model, while we've had some communication with the primary care community, that's been inadequate or incomplete. And certainly, as with any new medication, our role as physicians is to be skeptical and to be careful, and that's our appropriate place in the system. So we would expect there to be concern around prescribing a new medication and concerns over the drug interactions, and et cetera. So I think rapidly providing everybody with the tools and the knowledge they need is paramount. Again, dismissal of early symptoms as the sniffles. Perhaps people who've chosen to be unvaccinated and are over 70 are going to be more likely to be hesitant or resistant to advice. That's a hypothesis. I don't know that we know that to be true, but it seems that probably is true. So it may be a reluctant population that we're kind of aiming for. Again, that mistrust of COVID related interventions, the fact that this is new, there's only one peer-reviewed study, et cetera. Lots of reasons why the public may be reluctant to present themselves. So I'll hand it over to David to talk a little bit for a couple of minutes about some of the things we want to really rapidly accomplish in the next week or so to overcome some of these barriers, but also keep prescribing to the population that are likely to benefit the most, while at the same time giving you as much as possible to make this easier and get the treatment available to the people who would benefit. Again, to Isaac's point, recognizing that the major aim here is to prevent hospitalizations and death. David?
Great, thanks a lot, Chris. I did post, as people were asking in the chat, for some of the resources I posted in the chat, including the office script for the current eligibility to help your front staff triage people effectively. So next slide, please. So these are the current actions under consideration by the system. And I'm going to talk about three different buckets. The first is really, as Chris mentioned, a real need to clarify the eligibility and testing guidance. And so what's being considered is, building on the existing science table guidance to clarify the eligibility, and really, just like the script that I posted, support clinical decision-making for patients most at risk for severe outcomes for COVID-19. To Chris's point, I had a patient this week who called the office, day 2 of symptoms. He's 84, he had CHF and chronic kidney disease, but he was triple vaccinated and of course didn't meet the criteria solely based on that table that we just saw, because he only had 2 risk factors, but pretty frail. Was doing well. I think I may have tried to push him to a CAC had he not been doing well, but he had really mild symptoms. But I think starting to allow for some clinical judgment in these folks is going to be really helpful for us when we do speak to them. The testing guidance, looking at, allowing the target population for testing to be eligible for PCR testing. I do remind people that you can, right now, if you think somebody deserves treatment You can send them with a public health requisition signed by you, a family doctor, nurse practitioner, and send them to an assessment center to get a PCR, but also a self-administered rat. So if you had a rat done at home by a patient, that would be good enough to be eligible for testing. And really, the expected outcome here is to expand the number of Ontarians who can access Paxlovid, to make the guidance easier to understand both for providers and for patients, and ensure the target population can get testing quickly so that we know that what we're testing. The second set of actions under consideration is really to expand the access points to make sure that there's a good equity distribution, but also an efficient distribution of Paxlovid across the province. So one is obviously to optimize our current CAC pathway, link it possibly to other things like dialysis clinics or cancer centers, because a lot of these folks are going to be high risk. Introduce Paxlovid at community pharmacies. This is not community pharmacy prescribing, but rather a new way for patients to fill a Paxlovid prescription at a local pharmacy. So this would be consideration to family doctors or nurse practitioners filling Paxlovid, working with their community pharmacist to ensure it was safe for the patient, because we know there's a lot of drug interactions, but then the patient would be able to fill that prescription at their local community pharmacy. And we have lots of Paxlovid and lots more on the way. And there is a sense that we can definitely distribute it that way. And that congregate care settings where people really have difficulty accessing CACs would also be able to access Paxlovid through community pharmacy channels. There's a sense that we should possibly use a virtual assessment and prescribing. Obviously, very important to make sure that the testing is available through that virtual assessment, but also things like looking at lab levels, access to OLIS, all sorts of really important patient safety things that need to be in place in order to use virtual assessment, our virtual EDs or other virtual channels to make Paxlovid accessible. That way, with an outcome to increase the number of access points across the province, really leverage our CACs, use the broader distribution that we use for drugs, which are our community pharmacies, and also try to leverage our investments in our virtual urgent care network that we've made over the last 18 months in the province. And then lastly, and I think possibly most importantly, really proactive communications and actions, both on the public side and the clinician side. We know that there's that 5-day window to get people Paxlovid. And we, as Chris mentioned, a real shift from you think you have COVID, stay at home and self-isolate, to a real awareness of that, the fact that there is antivirals, how you would access them, and which patients it's important for them to seek care, to call their primary care nurse practitioner or family physician. The government is looking at establishing a patient-facing online eligibility tool, and then tailored messaging for some of the high risk and marginalized populations. One of the things obviously also is to ensure that our clinicians in the province feel comfortable supporting the patients and improving awareness of the fact that there are antivirals, how to get them, how to prescribe them yourself. And then also encouraging physicians to consider proactively identifying or pre-screening high-risk patients. Chris and I were chatting about this earlier in the week. I actually think it's important, if you're going to send out a message to your practice, I would send it out broadly, because all of our high-risk patients have loved ones. They all have other family members who may not see you. They may see a different doctor or not have a family doctor or nurse practitioner. And so if we actually have a public message that is easily consumable for everybody, we can use our patients actually as ambassadors to their family members and loved ones as well, with the broader expectation of broader awareness, understanding, getting people to access care, and ultimately, if there's expanded access, clear eligibility and testing guidance, then more people will be able to get therapy and have a discussion as whether or not that therapy will be useful for them. Next slide. For now, though, if you have any questions with regard to what's happening currently in your region, before any of these changes happen, you have a patient who you think is eligible, you're not sure, depending on where you live in the province, how to get them Paxlovid. These are the contacts in each of the Ontario Health regions. and each of them can help you navigate what your regional pathway is. You can reach out to them by email. And I think that's all our formal presentation for now.
Thank you so much, David. We'll go to the next slide just to highlight that we have these resources on Confused About COVID that do help you explain to your patients what these medications are and who is it that really should be calling us. So please, if you're sending email blasts or newsletters, you feel free to use these resources, confusedaboutcovid.ca. We've also kept the other ones up to date related to changes in isolation and testing guidance. So we can stop slides for now. And I wanted to actually just thank Andrea Chittle for helping us keep that resource up to date. And then I wanted to thank you, Chris and David, for giving us a heads up around what is coming down the pipeline, and also advocating for the role of family physicians in this tricky space. I think many of our colleagues had been talking about how difficult it was to access it via CACs, how people with symptoms, how does it make sense for them to even get to a CAC sometimes? And others, though, are saying that it's a difficult thing to prescribe Paxlovid. It takes 30 to 45 minutes, lots of interactions. We really need to kind of get up to speed about that. Sohel Goyal has put together a terrific a questionnaire that patients can use to actually identify themselves. So that's also in the chat for those of you who might have missed it. But just given all of that, I wonder if I could just turn it to you, Isaac, for a few minutes, just to speak briefly about some of the clinical pearls around Paxlovid prescribing, because I think this is we won't have we have a limited amount of time today, and we'll certainly be organizing another session to go over that in more detail because there's a lot to talk about. But maybe Isaac, you could highlight a few things.
Sure. Thanks so much. A couple of quick things. One, we're calling it Paxlovid. It's two medications, nirmatrelvir and ritonavir. It's the ritonavir that's the issue, in the sense that that's the one that has a ton of drug interactions. For everyone who's on the call, I appreciate there's many family physicians that care for HIV positive individuals and are very comfortable with ritonavir, and others less so. But yeah, ritonavir has a ton of drug interactions. Lexicomp is your friend. I mean, there's a million different online tools that you can use for drug interactions. I use Lexicomp, but whatever, the others are just fine as well. But yeah, I always just plug it in, and the key drug interactions you're going to have are with some of the oral anticoagulants, rivaroxaban, for example, apixaban, warfarin, with some of the anti-epileptics, and with some cardiac medications as well. Look it up. You just got to look it up. And sometimes, depending on the common ones are, for example, like anticoagulants, like maybe someone's on, I don't know, apixaban for atrial fibrillation. Well, you can stop that for a few days. That's okay to stop it for a few days if someone has atrial fibrillation. The risk of a clot over 5 days is negligible for the vast majority of people, not for everyone. But if someone's on that for, I don't know, a prosthetic heart valve, you kind of don't want to stop that apixaban. So obviously clinical, there's a lot of nuance, and your clinical acumen will certainly be stretched with some patients. Remember, a lot of patients don't have drug interactions, and they're going to be just fine with this. So drug interactions are a big issue. It's the ritonavir component. Look them up. And just because there's a drug interaction, most of the time you'll find a way around that. The other important point too is that if there's a drug interaction that you just absolutely cannot deal with, there's still drugs available. I mean, you can still send people for remdesivir. Yes, it's IV. Yes, it's 3 days, but we're increasingly using remdesivir in outpatient settings, and there's ways to navigate that. That's beyond the point of this talk. Lastly, just other counseling for patients. It's 3 pills twice a day for 5 days. That's a huge pill burden. It's pretty helpful. Again, the biggest benefit is for the at-risk people for hospitalization. Like a healthy 40-year-old who's fully vaccinated is probably not going to have any benefit from this, right? The whole goal is to keep people out of hospital based on the data we have to date. And you can counsel people that they might have an altered sense of taste. They might have some diarrhea. Sometimes people describe achy muscles and sore and achy muscles as well. So that's a couple of things to counsel people on. Last point, and then I'll stop, is I'm a big fan of decentralization of this medication. As we have greater access to it, I think it should be provided by family physicians. Appreciate who I'm speaking with here, but I also think it should be provided by pharmacists without the need for a prescription. There's some pharmacists that can do this well in urgent care centers, in emergency departments, in COVID assessment centers. I think at some point when we have enough supply and we can counsel patients appropriately, we could give it out proactively to patients at the greatest risk of infection and deal with this in a pre-exposure prophylaxis manner, or sorry, let's call it a pill in pocket approach, where they have the medications, they have the script, they have it at home. If they get COVID, they can start this on their own, but because they've been counseled ahead of time, I think that should be on the near to midterm horizon as well. And I'll stop there.
Thanks, Isaac. So we're definitely going to need to have another session to go over more stuff. I think the OCFP and Liz and others are advocating for more supports for family doctors to make it easier for you to do this. There have been some good tips in the chat about what to do. So please do look at the chat around that. There's also been requests for me to ask Isaac about Novavax. So I'm going to switch gears back to that because some people really want to know about it. So,
yeah.
Fan Wamang has said, my patient had severe adverse events to the Pfizer vaccine. There was a rare consequence where he required immunosuppression treatment. He now needs a third and fourth dose, but he's fearful of another mRNA vaccine. Is Novavax a good option for him? Lots of other people asking about Novavax, where to get it, and who it would be a good option for.
Yeah, so full disclosure, I think the NACI guidelines once again knocked it out of the park. The mRNA vaccines are superior, but there's some people who won't get the mRNA vaccines or can't get the mRNA vaccines, in which case, great, Novavax would be fantastic. Go for it. You can just call your local public health unit and they'll be able to walk you through how to get it. But it's around and people are getting it. It's just a bit of a stretch. So local public health unit will be able to navigate how to get access to this, but it is here.
Great. I think the other question that kept coming up too was this, you mentioned we should be going back to masking given what's going on. And I think people want to know, how can we best advocate for that? And are there specific studies or, evidence that you're using to say that, yeah, look, it works? Because I think people have also seen some mixed evidence. So I was just summarizing a few comments I heard.
Sure. I mean, obviously we have 30 seconds left, but there's an overwhelming amount of data from the pandemic over the last 2 years demonstrating the importance of masking and the benefit of masking at an individual level, at more of a community level, at a school level, at a county level, and then at country levels as well. I think it's fair to debate to what extent masks reduce transmission or protect the individual. That's a fair debate, but it's not, I think it's just unrealistic now to say, masks don't work and show those ridiculous, look at country A versus country B and try to make these oversimplified direct country to country comparisons. There's excellent data available. You can go online, you can see meta-analyses, this is all widely available, free. So, masks, quote unquote, work. We can debate to what extent they work, but they work. And then adding a value judgment, here's the value judgment to the data, is that my value judgment, and I think many others believe that based on the data we have to date, it is very reasonable to state that we should be masking, especially now during a sixth wave, to protect individuals, to at least take the edge off this wave, to protect vulnerable communities and to help reduce the overall transmission of COVID-19. I think it's a very reasonable thing to do. And many of us are strongly advocating for this publicly and of course behind the scenes. I don't know what else to say about them.
Appreciate it. So I'm going to give Liz you the last word here, and then we're going to close it out. So we can bring up the last slide, and Liz, I'll give you the last word because I know you've been answering questions and also behind the scenes advocating. We'll go to the last slide, Olivia. Thank you.
Yes, so thanks, Tara. There was, we were going to sneak in some, something on IPAC and PPE, but I have to tell you, there's just so much richness in this session, starting from, covering equity in terms of our, the way we're supporting our patients and all the questions that were answered on fourth doses. And now the opportunity for family docs to be prescribing Paxlovid. I don't really have anything more to say except for that, things just keep changing, and we're going to keep supporting you as we roll along, and such confidence in all of you, and so much pride for the work that you're doing to really be the backbone of the healthcare system and adapt. We know it's not easy. So check out our advocacy. We're pushing hard in the OCFP for family doctor issues to be front and center for all parties in this next June election. It's our website is lifewithoutadoctor.ca. And do join us April 22nd. There will be more to share at that time, as you know. So just gratitude to our amazing panelists for everything you gave today to all of us on the line.
So yeah, I'm just going to say thank you to everyone. Thank you to Francis, to Isaac, to Chris and David. Thank you for what you shared with us today and the time you took today, but actually all for what you've been doing throughout the pandemic. That's front and center, but also a lot of work behind the scenes that we know sometimes goes unrecognized. So thank you to you. Thank you, Liz. Thanks to our team who continues to work hard to bring these sessions to you every 2 weeks. We will see you again in 2 weeks. We're contemplating whether we should do something sooner than that if Paxlovid is released to us to prescribe earlier, and we know many of you would want to have more information about that. So we're contemplating something earlier. We don't know if that'll be possible, but we'll certainly do our best to give you a jam-packed session on April 22nd. We definitely want your comments around and suggestions of what you want to hear at our next session, what would be helpful. If you have speaker suggestions, please send those to us. And lastly, thank you to all of you. I know everyone is tired. Everyone had hoped we were going into COVID recovery, and instead we're facing, a huge wave and more responsibilities. But I know that you guys have it within you to keep going, and I appreciate all that you do. So thanks for joining us, and we look forward to seeing you again soon. Take care.